Kuzey Kıbrıs Diş Hekimliği Öğrencileri Birliği'nin bu yılki ilk DENTALKS etkinliğine hepiniz hoş geldiniz. Ben 5. sınıf öğrencisi ve bu yılki ENKET Genel Sekreteri Stajyer Diş Hekimi Serra Özdenak. Sizlerle yeniden buluştuğumuz için çok mutluyuz. Bildiğiniz gibi bugünkü konuşmacımız Sayın Profesör Doktor Arnaldo Castellucci. Kendisini davet etmeden önce Sayın Yardımcı Doçent Doktor Muhammed Abdülcelil hocamıza bugün bizlerle birlikte bu yayında olacağından dolayı çok teşekkür ediyoruz. Tekrar hoş geldiniz. Şimdi sözü bilimsel ekip delegesi sevgili Saba'ya bırakıyorum.
Hello everyone. I would like to welcome you all to this amazing phenomenon that is taking place right now. I'm Saba Mahmoudi, dental student at Near East University and member of scientific group of NCATS. We are thrilled and beyond grateful for having Professor Dr. Arnaldo Castellucci and Assistant Professor Dr. Mohammed Abdul Jalil here. And we can't thank you enough for giving us this opportunity. May everybody find this helpful in a way. I would like to invite Dr. Abdul Jalil, who is a remarkable endodontist, in order to mention the establishment and the resume of Dr. Castellucci.
Thank you, Sabah. Good evening, ladies and gentlemen. First of all, let me introduce myself. I am Assistant Professor Dr. Mohammed Abdul Jalil from Department of Endodontics in the Near East University. Before we start, I would like to thank everyone who contributed in the creation of this valuable presentation. I would like to welcome you all to this presentation. On this occasion, we would like to have a presentation from Professor Dr. Arnaldo Castellucci. Dr. Castellucci graduated in medicine and surgery at the University of Florence, and he specialized in dentistry and prosthodontics at the same university in 1977. He attended continuing education in endodontics courses at the Boston University School of Graduate Dentistry. Since 1979, his professional career has focused on endodontics. Since 2013, he has been a professor of microsurgical endodontics at the School of Specialization in Oral Surgery at the Università Federico II of Naples. He is past president of the Italian Endodontic Society, past president of the International Federation of Endodontic Association, active member of the European Society of Endodontology, and active member of the American Association of Endodontists. He has been editor of the Italian Journal of Endodontics and the Endodontic Informer. He is now the editor-in-chief of the Endo Tribune, founder and president of the Warm Guttapercha Study Club. He is a very well-known international lecturer with lectures all around the world. And now I would like to welcome the presenter, Professor Dr. Arnaldo Castellucci. I give the floor to Dr. Arnaldo and wish everyone a pleasant presentation.
Hello, everybody. And this is Dr. Castellucci. I'm an endodontist from Florence, Italy, as you already know. And I'm very happy and very proud. It's a big honor for me to be here and to share my experience with you. Honestly, I would have been much happier to be in presence in your country. But, you know, because of the virus and the COVID-19, this has not been possible. But I hope in the near future, I will be able to travel safely and to give my lecture in front of your eyes. Okay, now let me open my presentation and let's start. The topic I decided to share with you today is my personal clinical surgical approach to the presence of two root canals in the same root, tips and tricks. So let's see how we should behave when we clean, shape, and then obturate two canals in the same root during a non-surgical treatment or retreatment and during surgical endodontics. Let's speak first about the non-surgical endo. You know that two canals of the same root, they could have two possibilities. They could merge together, like in this drawing, which is represent the type 2 of the classification by Franklin Wine. and this is a transparent tooth showing the same thing, or they could be completely independent, like in the type 3 of the same classification from Franklin Wine, and this is a typical tooth. Well, our behavior, if we want to work safely, we need to take into consideration the fact that our behavior will be different during cleaning and shaping and during obturation, depending if the two canals are joining together or if they are independent. And of course, this will be referred to any root having two canals at the same root, like upper premolar or lower incisor, lower cuspid, but mainly is something that is referred to the mesial root of lower molar, a mesiobuccal root of upper molars. It is absolutely important when we start cleaning and shaping these canals of these roots that we try to understand as soon as possible if the two canals are completely independent or if they join together to a common apex. Because if they are independent, of course, we treat them independently. Each one will have its own working length, the reference point for the rubber stop, and so on. But if they are joining together to a common apex, the working length of the canal which is joining together with the other one will be shorter because the working length will be taken at the point where the two canals do join together, which means that, in other words, the working length of the canal which is joining will be shorter. That means that we will prepare a shorter taper preparation, which means that we save time and, most importantly, we save denting. Now, in order to work safely when we clean, shape, and prepare our root canal systems, we have to follow one absolutely very important rule that I will show you more in detail later, but I tell you now. And the rule is prepare one canal at a time. I know that not many people follow this rule, and actually, if you go to any endodontic meeting, you will see very easily on the screen X-rays where the colleague put 3 or 4 instruments in 3 or 4 canals of the same tooth, trying to check the working length of 3 or 4 canals at the same time. In my opinion, and in my hands, this is absolutely a mistake. This is wrong, for the simple reason that every root canal has its own working length, its own reference point for the rubber stop. It requires its own precurvature to the stainless steel instrument that will negotiate at the beginning the root canal. It will require, in upper molar especially, its own orientation of the X-ray machine. So it's very difficult to check 3 or 4 canals at the same time with the same radiograph. So when I say prepare one canal at a time, it means that prepare one canal at a time, start to finish, which means that you don't go to the second canal of the same root if the first one is not ready to fit the cone. I'm not saying that you will obturate. I say ready to fit the cone. Why? Because I tell you which one is the easiest and the simplest way to understand if the two canals are independent or if they join together. So if you prepare one canal at a time, you decide to go from the easy one to the most difficult one. So in upper molar, you will start with the palatal, then you will go to the distal, then to the mesial, MB1, and then you will go to MB2. In the lower molar, you start with the distal, and then you go to the lingual, mesiolingual, and then you go to the mesiobuccal. And when you start to negotiate the MB2, for instance, in the upper molar, that means that the MB1 is already clean shaped and ready to fit the cone. And then what do you do to check if the canals are independent, yes or not? You introduce the gutta percha point in MB1, and then you start negotiating MB2. Then remove the file from MB2, remove the gut aperture point from MB1, and then you look at the surface of the gut aperture point that you remove from MB1, and you look for any kind of impression, a scratch, sometimes a tunnel. So you know from the gut aperture point that the two canals join together, and you also know where they do join together. So if they join together 5 millimeters from the common apex, from the common foramen, the working length of MB2 will be that same amount shorter, which means that you develop a shorter preparation taper, which means that you save dentin. Why it is so important to save dentin? Look at the cross-section of the lower, the mesial root of the lower molar and the mesiobuccal root of the upper molar. You see that there is not so much dentin around, this is the lower molar, and around the mesiolingual and mesiobuccal on the distal aspect, which is called the danger zone, where you have much more dentin in the mesial aspect of the same canals, which is called the safety zone. This is even more important for the upper molar, where you know that the root itself is becoming thinner and thinner, going from buccal to palatal direction, which means that around MB2, you don't have the same amount of dentin that you have around MB1. So it's very easy. If you enlarge the MB2 too much, it's very easy to make a strip perforation, okay? So this is the reason why it's so important to know from the very beginning, as soon as possible, if the two canals of the same root are joining together or if they are independent. Look in this other study made by my friend from University of Turin, Ilio Berutti. Look the thickness of dentin on the distal aspect towards the bifurcation. How many millimeters we have in this area, okay? We have around 1 or 1.1, 1.2 millimeters, which means it's very easy to make a strip perforation. On the other hand, on the other side, on the mesial aspect, okay, we have much more dentin, and that's the safe area. So I repeat, the rule number 1 to work safely, always prepare one canal at a time, which means from start to finish, which means that you go to the next root canal if the first one is not ready to fit the cone. And as already told you, the sequence in the lower molars is always start from the easy canal, which is the distal in this case, and then you go to the mesiolingual and then the mesiobuccal. Why you prefer, or I prefer the mesiolingual first and then the mesiobuccal? Because the mesiobuccal quite often, if not always, has a coronal curvature, so that and that's the area where it's very easy to make a strip perforation. So if you know that the mesiobuccal is joining together with the mesiolingual, your shorter preparation will be safer and you don't run any risk of making strip perforations. The two canals, they are merging together in a common apex. When they merge together, they have an extra and very dangerous curvature. And here it is, okay? So dangerous because if you pretend to go to the same working length in a case like this, after going through a curvature in one direction, then you have a curvature in the opposite direction. And this is the reason why many times in these canals, many times, at least in my practice, in the mesiobuccal canal of lower molar, we find broken instrument. Look at this other case. MB1 and MB2, they join together, and MB2 is joining together with an almost 90 degrees curvature. So to pretend in this canal to go to the same working length, to the same foramen, there is no reason, first of all, and then it's extremely dangerous because you are asking your instrument, after making a curvature to the left, to make a 90 degrees curvature to the right, which is very difficult or impossible, very risky. You may fracture the instrument. So let me again tell you why I prefer to work first in the mesiolingual, which has a more straight line access to the apical 1/3, and then go to the mesiobuccal. Look at this case. The mesiolingual, the mesiolingual has been already prepared when I introduced my K file, O8 K file in the mesiobuccal canal. Okay, and as soon as I introduced the instrument, I noticed that the handle and the rubber stop, they go to the lingual and to the distal, which means that I have a coronal curvature in the canal, which is pushing the instrument to the opposite side. And I repeat, I am negotiating here the mesiobuccal. Okay, that means, looking at the instrument in this position, that means that I cannot take my working length. I cannot work to the foramen because I don't have a straight line access. Okay, then if I need, I modify my access cavity in order to have a straight line access, and then only when I have the straight line access, now I can take the instrument to the working length, and now I know that I have a straight line access at the working length because the rubber stop is not going like before to the distal and to the lingual, but is referred to the same mesiobuccal cusp. So this is a suggestion to make sure in this canal that you have a straight line access. So no risk of making strip perforations, okay? No risk of breaking the instrument because of the sharp curvature. Make sure that the rubber stop, when you are in the mesiobuccal canal, is referred to the mesiobuccal cusp, okay? Here is the same in the drawing. I cannot work and I cannot take my instrument to the working length in a situation like this, when the instrument goes to the distal and to the lingual and is in the mesiobuccal. So I have to modify my access cavity, remove this triangle of dentin, and now I can take my instrument to the working length and start to negotiate the canal to the working length if it is independent. But when I'm trying to do this, okay, and I already have the mesiolingual, the carapace point, now is the time to check if the canal are joining together or they are independent. Where do the instrument break? Most of the time, look where they break. They break in the mesial root of the lower molars. First molar, second molar, the same here, the same here. And they break. This is an extracted tooth when a student was practicing during a workshop. When you have a straight portion of the canal, very long, okay, and the curvature in the middle, that means that the curvature is very much coronal. And then if you use the instrument with the increasing taper, in this case was a ProTaper S1 with a progressive taper, it doesn't matter if the instrument is in night eye and has a super elasticity, but the cross section is pretty large, and so the instrument, even though it's flexible, is not so flexible, and then it breaks. Which one is the easiest way to understand the real anatomy? Look at this case. This is a case that I treated many, many years ago. At that time, I didn't have the microscope, I didn't have the Cbct, I didn't have anything. But I knew already few rules to follow. This is a lower second, maybe third molar, with two broken instruments in the mesial canal of the lower of this of the mesial root. Okay, so with a 8 or 10 K file, I was lucky enough to negotiate and bypass one canal, bypassing the broken instrument, and just enlarging the canal around the broken instrument came out very easily. Then I complete my cleaning and shaping, and then I start to negotiate the other canal where there was the other broken instrument. But because, as I told you before, the previous canal was already ready to fit the cone, the next step I did is I introduced a gutta-percha point in the canal where the instrument was already removed, and then the file where I was negotiating and bypassing the other fragment. And look what I found. This is the gutta-percha point that I removed from the other canal. I know that the two canals are joining together, and they join together this far from the foramen. So my working length became shorter, and I saved time, I saved denting, and I explained the patient, listen, I don't have to remove denting and waste my time and waste your precious denting just to be happy and proud and show you the other fragment removed. Because the problem that we need to solve when we have broken instrument inside the root canal is not just to remove the piece of metal, but is to clean, shape, and obturate the portion of the canal which is apical to the fragment. And because in this case, the canal apical to the other fragment has been already clean, shaped, and disinfected coming from the other canal, there is no reason to spend time and remove denting trying to remove also the broken instrument. The patient can survive 200 years having gutta-percha in the canal and a piece of fragment in the middle. So here again, you see that the two canals were joining together. I am condensing gutta-percha in the canal for sure was the mesiolingual. The patient is informed that the fragment can stay there. So this is my immediate post-op, and you can see probably here with the radiopacity that the fragment is still there. And this is a 2-year recall evaluation, and the patient is perfect, no lesion, no pain, no nothing, okay? This is a similar case where the patient, who is a lawyer, and he was a very good friend of the dentist who had this accident. He broke a ProTaper Universal F3, pretty large, pretty big, with a 0.9 taper in the last apical millimeters. So not so flexible. So he broke the instrument, and as you will see soon in the video, trying to remove it, he broke also a very narrow stainless steel file, maybe a number 10. He made also a very little perforation. And then he said, oh, you know what, my friend, you should go to Dr. Castellucci. He's excellent. He's able to remove broken instrument and blah, blah, blah. So he made many compliments about me. And so the patient came to me saying that, asking me to remove the broken instrument and telling me that the doctor, his friend, told him many nice things about me. I say, thank you. I'll do my best. But I cannot guarantee that I will be able to remove such a big file broken around a curvature. This portion was straight, and this is after the curvature, okay? So this is the canal with the broken instrument. In this video, you can see this is the ProTaper, this is the K file, and this is the perforation. Of course, I didn't inform the patient that not only his friend broke the ProTaper Universal F3, but he also broke a K file and they made a perforation. However, I didn't want to spend too much time trying to remove the broken instrument. So I spent my time to clean and shape the other canal, the mesiolingual. And when the mesiolingual was ready to fit the cone, I started to negotiate trying to bypass the canal with the broken instrument, okay? Then I introduced the gutta-percha point here, the K file in the other one with the broken instrument. And this is the confirm that the two canals were joining together. And then I told the patient, listen, the two canals are joining together. I already cleaned and shaped the apical portion, there is no need to remove that piece of metal, okay? And then I showed the patient also what I found, not only the carapace point, but look at now you see the perforation here, the protaper, and the little K file around it. This is the K file broken and the perforation. But look what happens when I irrigate. I irrigate the canal with the broken file, and you see the irrigating solution is coming up in the other canal to confirm that the two canals are joined together. Then when I take a small suction tip, I suction the irrigant from one canal, the one with the broken instrument, and you see that the irrigated solution disappears from the other canal. See, so after showing this, the carapace point and the irrigation to the patient was very well informed, and he left with no more pain, no symptoms, but the broken instrument was still inside here, okay? Let me show you another situation where it's so important to understand if the two canals are joined together, yes or not. Well, this is a lady who was referred to me a couple of years ago from another town near Florence, about 1.5 hours by car. And she was referred to me by a colleague who was trying to find the calcified canal in this upper first premolar, upper left first premolar. He was not able to find the canal completely calcified, so he referred the patient. He stopped on time, because sometimes they don't stop on time and they refer the patient after making the perforation. He stopped on time, and then he referred the patient to me. Under the microscope, using ultrasonic tips, little by little, I was able to find the mesiobuccal canal. This is an intraoperative X-ray, just to make sure that I am inside the original canal. And this is the canal checking the working length. There is a distal curvature, a little radiolucency. And then I started with the ultrasonic tips under the microscope. I started looking for the mesiopalatal, and I couldn't find it. And then I told the patient, listen, let me remove the rubber dam and put some temporary filling, but let me take a Cbct, an intraoperative Cbct, because I want to see if I was going in the right direction or not. But more important, I want to know if the two canals, I want to see if the two canals join together to a unique common foramen. As you see, this is the coronal view, and you see that this is the canal I already prepared, and this is my attempt to find the palatal canal I was going to match to the palatal, and I stopped on time, and to match to the distal again. And here is in the axial view, where the canal is completely calcified, not possible to see. But then in the apical area, what I found is the one single foramen. So I said, lady, I have good news for you. There's no need to find the other calcified canal, because the canal is joined together with the other one that I already found and I already prepared. So I will stop now. And let me tell you another thing. I told her, you have a sinus tract. If you come back to me for the final obturation and the sinus tract is completely healed, this will confirm that the canal were joining together, and I clean and shape the only one which was responsible of infection around the apex. And so I repeat, there is no need to look for the other completely calcified canal. This is exactly what I did. This is the rendering in 3D, the lesion. You see the lesion. In the corona, you see the lesion again. This is my post-op. And this is a 2-year recall. No more lesion. And of course, after 1 week, when the patient came back for the final obturation, the sinus tract was already disappeared. This is another situation. The canals are completely calcified, and I have difficulties finding the other one. Also, the pulp chamber was completely calcified. I'm measuring here the distance between the occlusal surface and the floor of the pulp chamber, 6.9 millimeters. Measure before you go too deep and you make a perforation in a completely calcified canal. So I was able to find the distal, and I was able to negotiate it, and I was able to find and negotiate and prepare one of the 2 mesials. Then I decided to take a Cbct. You see the lesion. This is the sagittal. This is the coronal view. In the coronal view, you already see one canal has been prepared. The other one is calcified. I was not able to find it. And you already see that the 2 canals are joining together to a common apex. So let's see now again the coronal view. You see one canal prepared, the other one completely calcified. In the sagittal view, you see the lesion, but the most important is the the axial view. Okay, so let's follow the axial view, and you see that in the axial view, in the apical portion, you only have one foramen, one canal, exactly in the middle of the root. That means that the 2 canals are joining together. So stop looking for the other one, because the apical portion of the canal has been already clean shaped and now is ready for obturation. Look how nice. Only one foramen at the very end. So this is the confit, my post-operative film, and this is a 1-year recall with a nice healing. Let's see now the upper molars. The sequence in the upper molars is, as I already told you, always start from the easy and go later at the end to the difficult one, because the difficult in the meantime will be by itself a little bit easier. I will never, ever start looking for the MB2 canal, never. I always start from the palatal. Then, because with the same X-ray machine oriented, I can also already see the distobuccal. Then the second canal will be the distobuccal. Then I go to the mesiobuccal. Each one of them has been prepared, start to finish, ready to fit the cone. And now that I'm ready to start to negotiate the MB2, the MB1 has been already clean shaped and ready to fit the cone. Let me go back for a second. I hope you notice that the foramen, the opening on the pulpal floor, on the pulp chamber, the orifice of the MB2 canal is smaller than the orifice of MB1. This is because the 2 canals, in this case, were joining together. The working length of MB2 was shorter. I prepare a shorter preparation, taper preparation, and this is why the orifice in the pulp chamber looks smaller. Okay, so 1, 2, 3, and 4. Let's see now in reality. Again, I already prepared the palatal, which is down here, the distobuccal, the mesiobuccal, and now I'm trying to negotiate the MB2 canal. Irrigation with EDTA because the canal is pretty narrow and calcified. And I start to move my 08K file. Maybe it's difficult at the very beginning, but then it becomes very easy. That means that I enter in the portion of the canal which has been already clean and shaped coming from the other one. So now the gutta percha point is in the MB1, and I'm negotiating and moving the file in the MB2 canal. So move the file up and down a few times, then remove the file first, and then remove the gutta percha point. And now look carefully the little impression from here. Okay, so that means that the taper preparation will be that much shorter. So this is the orifice before, and this is the orifice after. As you notice, the orifice is smaller of MB2 compared to the orifice of MB1. This is, again, the cross-section of the mesobuccal root of an upper molar, and you see that the root becomes narrower and narrower in the palatal direction, and we don't have the same amount of dentin around MB2, not the same that we have around MB1. So if we can save dentin for safety, I think is a good idea. Now, if the two canals are joining together with a very acute angle like this, to go to the same working length, maybe, I say, cannot be a problem. Maybe you over-enlarge the foramen because you go there coming from another direction when the canal and the foramen has been already enlarged. So you don't need to over-enlarge it. But in the case that you already saw, that I showed you before, to pretend to go to the same working length coming from MB2, where you have a 90 degrees angle, is very difficult or impossible and very risky. So again, what do? Prepare completely MB1, and when you are ready to negotiate, enter in the MB2, having the gutta percha point in MB1, and look what happens. And now you know that the working length of MB2 will be maybe 4 millimeters shorter, okay? If the other working length was, I don't know, maybe 21, now the working length here will be 18, okay, not more. Why it is so important to have a straight line access in the MB2 canal, and also trying to know as soon as possible if you have if two canals independent or if they join together. I wish I had your face in front of me now, because usually when I cover this topic, I ask a question to the audience. Did it ever happen to you to see the orifice of the MB2 canal and try to negotiate it, and then you enter for maybe a couple of millimeters, and then you stop and you don't go any deeper? And most of the time, if not always, I see all the faces saying, yes, I had this feeling. It happened to me. And then I ask, why you think that you don't go any deeper? And most of the time, the answer is, well, I think that the canal is calcified. No, the canal cannot be negotiable for the first 2 millimeters and then become calcified. It's exactly the opposite. Because thank God, calcification, they always progress in a coronal to apical direction, so that the pulp chamber can be completely calcified. The coronal 1/3 can be completely calcified. In the middle and apical 1/3, 2/3, the canal is still open, patent, just waiting for you. So you don't enter any deeper because you don't have a straight line access, okay? If this is the floor and this is the mesial wall, the mesial wall makes a very acute angle with the floor, and the entrance is with this angle. So what do we need to do, not with high speed or slow speed bursts, but with ultrasonic tips? We need to remove this portion of the mesial wall in order to have a straight line access using the ultrasonic tips. specifically designed for this purpose, that remove the gray portion of the drawing, which is the mesial wall of the access cavity, which makes it as a sort of protrusion of dentin towards the floor, and at the same time open the little groove that contains the orifice of the MB2 canal. And now you can enter. This is the orifice of the MB2 canal with the start X from the splice corona number 2. You can work with the tip to open the groove containing the orifice of the MB2, like this. And then you work with the side to remove that protrusion of dentin so that you are able now to enter, negotiate to the very end, having a straight line access like this. Okay, and these are just examples of a canal joining, or independent. Many times they are independent. And what about irrigation? As I already told you, the irrigation is another way to confirm that the two canals are joined together. Look at this. You irrigate one canal, and you see the irrigating solution coming up in the other one. And then if you use a small suction tip, you suction from one canal, and the irrigating solution disappears from the other one. So now you know that they join together. Or to know exactly where, how many millimeters from the common foramen they join together. As I already told you several times, got a puncture point in the mesiolingual already prepared, and the K file in the mesiobuccal. Move the file and then remove the file first, and then remove the gutta percha point. And now examine the surface. Look, and you know exactly they join together, and you know how far from the common foramen they are joining together. And then you adjust your working length. This much, this amount shorter, okay? Look at this other case. Speaking about canal. Well, this is a case which is funny for other reasons, because the colleague was so ignorant and so, let me say, stupid. He looking for the canal, make big perforations, and was not happy. So he broke the entire working portion of the rotary file. With the ultrasonic tip, I remove the broken file from the perforation, just transmitting vibrations. And here is the broken instrument. Then I started to look for the canal. And the canal, where are they? They are here in this little groove. Okay, this is one. And now this is the other one. These are the perforations. I irrigate one canal, and you see again the irrigating solution coming up and then disappearing with the suction tip. This is the gray MTA to prepare the perforations, and the same two canals in the other route. Okay. So this is the pre-op, and this is my 3-year recall evaluation. And what about obturation? This is a funny case where I was fitting the cone in one canal, and I can see the tip of the gutta percha point in the other one. It's obvious that the two canals are joined together. Now, if the two canals are joining together, we need to be careful also when we do the obturation. So we want a gutta percha point that will fit perfectly in the canal prepared to the working length, to the foramen. And then in the other canal, which is joining together, the gutta-percha point can be any gutta-percha point that will then later will be pushed against the first one. It doesn't have to be so precise. It doesn't have to be a very precise tuck back and so on. Very important, however, introduce both gutta-percha point in the canal, but start the compaction only of the gutta-percha point, which is fitted to the foramen. Make sure that you move the gutta-percha in the apical part, and then condense and do the compaction of the other one until the case is completely compacted. Because if you push the gutta-percha point of the canal joining against the main gutta-percha point in the main canal, you block with your second gutta-percha point, you block the movement of the first one, and then it will be difficult to move apically this gutta-percha point in the apical ramifications. Okay, so fit both of them, but condense only the one which is fit to the working length. And when you are happy with this compaction, now you compact the other one. So remember, they could merge or they could be independent. They could be independent, but they can have communication. Okay? So during the obturation, if you know that the two canals are independent, do something similar to what I already told you, which means that you introduce both gutta-percha point this is the gutta-percha point in the other canal. We are speaking about the mesial canal of a lower molar, because even though they are independent, they could have communication. As you see, let me show you soon what happens. And you do the compaction in parallel. You compact one and then the other one. Let me show you now. I am compacting the gutta-percha in this canal, okay? And look what happens. You see that the sealer goes. Did you see? Let me show it again. When I condense the gutta-percha in the other canal, did you see the sealer entering in the previous one? Which means that the two canals are communicating somewhere. Look, I keep compacting and more sealer is entering in the other canal. This is the reason why it is important to introduce both gutta-percha point in both canals and do the compaction in parallel at the same time, one at the other. Because if you put only one and you start condensing that one, through the communication, some obturating material can enter in the other one, which is still empty, and then will block the gutta-percha point that will not enter to the right working length. That's why, I repeat, it's so important to introduce both of them if they are independent, because they may communicate somewhere along their length. As you see here and here, independent but communicating. Look at this other case. This is a lower second molar, one canal in the mesial and one canal in the distal. Apparently, they are absolutely independent, okay? The foramen is here in the mesial, the foramen here in the distal. But they may communicate somewhere. That's why I introduced the two gutta-percha point in the two canals, and doing the compaction, look, wow, look how many big in the isthmus communication they had, okay? Two canals of the same root in a quite unusual anatomy. Let me show you. These are other cases where this is a lower second molar, where I have one canal in the mesial and two canals joining together in the distal. Another case, one canal in the mesial and two in the distal. Another communication between the distal and the two mesials. Many unusual communication here. The two canals in the distal lingual, distal buccal, the distal buccal and the mesial buccal were joining together. And here the same. The mesiolingual, the mesiobuccal, and the distal they were joining together. The mesiobuccal and the distal joining together. Then we have the C-shaped canal, of course, where the canal start joining together from the orifice down to the foramen. This is a typical example of a C-shaped canal, where you are in the middle of the sea and you think from the X-ray that I was thinking, oh my goodness, I made a perforation. Relax, there is no perforation. You are, if I go back for a second, you are entering exactly here, okay? Different kind of, this is another. Apparently, it looks like a normal, common second molar, but there's a sort of a C-shaped canal. Again, it looks like I am in the perforation, in the bifurcation. Is a C-shaped canal. Let's see now a few things about surgery. In surgical endodontics, we have also to pay attention when we do surgery or microsurgical endodontics in one root having two canals in the same root. Remember that the two canals of the same root, they always, I say always, have an isthmus. The isthmus used to contain pulp tissue, okay? Now it contains the derived tissue or necrotic tissue or bacteria. So even though you see two separate orifices after you make the bevel, which is called bevel, but it's not a 45 degrees bevel like it used to be years ago. Now it's a 90 degrees to the long axis of the root. Even though you don't see an isthmus, you see one orifice here and one orifice here. Remember that the isthmus is always there, even though you don't see it. So don't be proud to show that you found and obturate during surgery the two separate canals. The two canals must always be connected, preparing the isthmus. The isthmus MB1, mesiobuccal, mesiolingual, and this is the isthmus in this beautiful image at the scanning electron microscope given to me by my friend from San Diego, Gary Carr. Now, are you surprised if I tell you that isthmus is present in the maxillary molars in the mesiobuccal root 95% of the times? No surprise, because 95% of the times we have MB1 and MB2, which means that we have the isthmus. This is another case, another image from Gary Carr, and this is an extracted tooth where you see that the colleague made the mistake not to prepare the isthmus. Another case, still from Gary Carr. This is a lower molar. The isthmus was not prepared. If you make a very acute angle, instead of working 90 degrees to the root, you might miss the lingual anatomy. So if you, let's assume that you start working in a mesial-buccal root of an upper molar. You make your bevel, and this is the surface of your bevel, and you see the orifice, one orifice, completely asymmetrical compared to the cross-section of the root. That means that you have somewhere you have to make a bevel deeper and deeper until you see the orifice of the MB2 canal here. Okay. And remember that the bevel will be deep enough when you have the same amount of dentin on the palatal aspect of MB2 and on the buccal aspect of MB1. And then remember always to connect them, preparing the isthmus. This is a typical case. Very useful during surgery is the use of the methylene blue that will give the color to the periodontal ligament and to MB1 and MB2. So let's see the steps to prepare the isthmus. I am working now in the mesial-buccal root of an upper first molar, methylene blue, irrigation, the mirror, and here you see this is the MB2 and this is the MB1. I don't have enough dentin palatal to MB2, so I need to go deeper. The little probe to show the two canals, MB1 here and MB2, not enough dentin. Okay, so I need to go deeper. So let's go a little bit deeper until I have enough dentin palatal to MB2 canal. In the meantime, I want you to appreciate the control of the bleeding. There is no bleeding at all, and the patient is alive, of course. Methylene blue, irrigation. Suction, and now the mirror. And now the mirror is showing me that around MB2, I have enough dentin to make my retro prep. And this is the MB1. Okay. This is my case many years ago. I was very proud to show that in this case, I found two canals, and these are my retrofill in amalgam. But then the patient came back to me with a sinus tract, and the case was failing because I forgot to prepare the isthmus. So I removed my old amalgams. I prepared the isthmus. This is a very, very old case. So this is one single retrofill with the shape of a banana or number 8 or whatever. So this is a 6 month, and this is a 3-year recall after preparing the isthmus. This is another case where the oral surgeon didn't prepare the isthmus. This is a case made a few years ago, but still using amalgam, like the oral surgeons, they still like to use amalgams. I don't know why. So let's see now how to prepare the isthmus. To prepare the isthmus, there are several steps to follow. Making with a very sharp explorer designed by Gary Carr is called CX1, Carr Explorer number 1. Make a tracking groove between MB2 and MB1. Then with the ultrasonic tip, without irrigation, make that groove a little bit deeper. Okay. Then when it's deep enough, start the irrigation and you go back and forth several times from MB2 to MB1, MB1, MB2 until the isthmus is completely prepared and now is ready for to be obturated. So this is the tracking groove. This is without irrigation, making the tracking groove a little bit deeper. And when it's deep enough, ask the dental assistant to open the irrigation, and you keep going until you make the isthmus deep enough to receive the MTA obturation. This is the groove. Let me go just. And this is the isthmus prepare. And this is the final obturation with white MTA. So these are the several steps and the 2-year recall evaluation. Okay, I am perfectly on time. Maybe I am 2 minutes late. So I want to thank the university and Saba who contacted me for the invitation. It has been a big honor, a big pleasure, and really I hope to be personally in your beautiful country soon, next year, somewhere, in person. So I want to thank for organizing my lecture. I want to thank the audience for the kind attention. And I finished showing you my last work. 2 years ago, I published this textbook on microsurgical endodontics. It's a textbook about surgery, microsurgery made through the microscope, and it's full of illustration and full of also QR codes where you can put your iPhone in front of the QR code, and then you can download videos. And you have video from how to provide anesthesia up to the removal of the suture. Every single step of the surgery is well documented, also with videos. And this is my very last work, which has been published only a few weeks ago. Right now is in Italian, but next year I'm working on the new edition. The next year will be available also in English. This is a textbook on endodontics, which starts from a little chapter about history, a little chapter about embryology, and in 3 volumes, and there's 1,700 pages and many QR codes and videos. Will cover endodontics from embryology to the restoration of endodontically treated teeth. So you cover all the aspects of endo. So thanks again for your kind attention. And if you have questions, I'm here ready for you to give you the answer. Thanks again. And I'm here for your question if you have.
Thank you so much, Professor. It was really useful lecture, and I'm sure that everyone enjoyed it. Now we want to ask you some questions that audience already wrote in the comments. Kadir Aslan asked that, are there any important points that we should pay attention while applying MTA?
This is regarding MTA both in non-surgical and surgical, I think. Well, in the only thing to be careful, if you have a perforation and a big lesion on the other side, where it is very difficult to have a control of the material. I know that the material is biocompatible, but I hate to push material where it is not necessary. So in this case, I make a barrier on the other side of the perforation. Okay, so the patient is under anesthesia and for sure is under antibiotics. I put a barrier of resorbable collagen inside the perforation to act as a matrix, and then I introduce my MTA without any risk of overfilling. Okay, in that case that I showed you, I didn't use any barrier because the perforation was quite recent. And so the little amount of granulation tissue which was there act as a perfect barrier, preventing any extrusion on the other side. But other times where I had a big lesion with not old lesion and not so much granulation tissue to act as a barrier, in that case I use resorbable collagen. So during surgery, the MTA must be of the right consistency, not too wet and not too dry. I use a carrier, very nice and very useful, which is, let me tell you that I don't have any economical interest with any material or instrument that I'm mentioning to you. But in surgery, very useful is the carrier made in Switzerland by a company which is called Produit Dentaire from Switzerland, and the carrier is called MAP system, MAP, micro apical placement system, to deposit inside the retrocavity of the retroprep the right amount of MTA, which is the right consistencies. Then I condense it with my small pluggers, and then I do the finishing, and then it's ready for suturing. That's it. Easy.
Yes, thank you, Dr. Arnaldo. Thank you again so much for your informative and valuable talk. And our esteemed participant conveyed their thanks to you, Doctor. We have another question from Baver Tumbash. The question is, some teeth become discolored after root canal treatment. What is the reason for this and how can it be prevented?
Okay. Okay, good question. Thank you. Well, of course, we are talking about the front teeth because
Yes.
it becomes discolored a molar. Who cares?
Right.
But in the front teeth, it's an aesthetic problem. So the first thing to do is to avoid to leave not only sealer but not even gutta percha inside the pulp chamber. So the obturation of with the gutta percha and sealer must be at least a couple of millimeters apical to the cemento-dentinal junction. Enamel dentin junction. So 2 millimeters below the gingival margin, in other words. And then obturate the pulp chamber and the orifice of the canal with some white material. I don't suggest to use composite because the composite, if for some reason we have to enter in that pulp chamber or at the orifice of the canal or inside the canal to make a post in the future, to make a post space or whatever, then to remove the composite and recognize the composite from the dentin, sometimes it's not so easy. So I suggest to use veto-ionomeric, glass ionomeric cement in a white color, but the color is a little bit different from the white dentin. So in the future, if you have to remove it to make a post space, it's easy to recognize it. That's all.
Yes,
So
thank you,
be
Doctor.
careful not to leave any material inside the pulp chamber.
Okay.
Thank you, Doctor. Also, Beste Kaya asked that, is there an extra case compared to normal that we need to determine before performing treatment in tooth whose root canal treatment is really difficult?
Is there an extra case compared to normal that we need to determine? Well, if we think that the root canal treatment or retreatment is really difficult, before I even start that case, I take a Cbct. I installed a Cbct a few years ago, and I'm very happy to have it because, as I already told you during my presentation, sometimes I take an intraoperative Cbct to see exactly where I'm going in the very difficult calcified canal, which is important instead of keep going and maybe make a perforation. I'm not allowed in my town to be the one who makes perforation. I'm allowed to repair perforation, made by somebody else, but not to make my own perforations. So I suggest to have a CBCT. I don't take a CBCT for every single patient who comes to my office, but if I have a surgery in a lower quadrant, I want to see where is the mental foramen. I want to see where is the canal or the inferior nerve, or in the maxillary sinus, or where is the maxillary sinus, and so on, for surgery. In a non-surgical case, like in the case that I showed you where I was not able in a lower molar to find the other calcified canal, I take a CBCT. Sometimes I take an intraoperative CBCT, so I know where is the problem. Just to give another idea, I received a few days ago an upper premolar, completely calcified in an old patient, almost 80 years old. The canal was the tooth, the premolar was an abutment of a long bridge, okay? And from the x-ray, I could notice that the crown was oriented like this and the root inside was oriented like this. Plus, the root was very thin and calcified. And there was a lesion in the sinus tract. And so I said, of course, I took the CBCT to see the anatomy, to see the presence of the canal. And then with the microscope, I cannot imagine working without the microscope. I don't know how popular is the microscope in your country, but in Italy still, many people have the microscope, but still not everyone who perform endo, unfortunately. But very, very important to have the microscope. And today I say also to have the CBCT. So with the CBCT and the microscope, now the difficult case becomes, I don't say easy, but you can start and be confident that you will safely and successfully will arrive to the end. Okay.
Yes, thank you, doctor. And we have another question from Nursema Gurj. Which canal should we put the gutta perca in to find exact the working length? I think she means the two canals shared one apex.
Yes, when the two canals share one apex, let me repeat a very, very important thing. Excuse me. Remember the rule number one, that not many, unfortunately, follow. This is something that I learned many years ago when I was a student at Boston University. I talk about 40 years ago, many, and I still use and follow that rules. Prepare one canal at a time. Sometimes I see many times people jumping from one canal to the other with the same instrument. I mean, in my hands, it doesn't work, because I told you, every root canal has its own working length, reference point for the rubber stop, and so on. So prepare one canal at a time, and in the two canals of the same root, prepare the one which is easier. And the easiest is in the lower molar is the mesiolingual. Start to finish means that now you are ready to fit the cone. Then you want to negotiate the mesiobuccal. Okay, start to negotiate. And when you think you are making progress, introduce the gutta percha point in the mesiolingual. The same is valid for the upper molar. Prepare MB1. When MB1 is ready to fit the cone, put the cone in MB1 and start to negotiate the MB2. And then remove the file, remove the gutta percha point, and now you see the surface of the gutta percha. If you have a scratch, any kind of impression, 5 millimeters from the foramen, because that gutta percha was fit at the foramen, not 0.5 or 1 millimeter shorter. The working length is another very important topic. It's a very controversial, I know, okay? But I don't stop 0.5 millimeter or 1 millimeter or 1.5 or 2. I stop where is the very end of the canal. And the end of the canal is not the cemento-dentinal junction, is not the constriction, is not nothing, but is the foramen. this is the end of the canal. So my gut aperture point will be exactly at the foramen in the MB1 or in the mesiolingual. Then the file in the mesiobuccal, and then I know how far from the foramen the mesiobuccal is joining together with the other one. And then I will stay the same amount shorter during my preparation. Okay?
Thank you.
Okay, thank you,
Welcome.
doctor. Also, Ali El Kasim asked that after using NTA as a retrograde filling, sometimes discoloration can be seen in the tooth. What is the reason of this?
Well, let me tell you honestly, I noticed a discoloration using MTA, but not as a retrofilling at the apex, because 3 millimeters of even gray MTA up at the apex will never be responsible of any discoloration of the crown. At least never happened in my hands, my office. I noticed discoloration when I repair a perforation very, very superficial in the coronal 1/3 of the root of a upper cuspid, and I repair the perforation with white MTA from Desplacirona, ProRoot MTA, just to mention the name. Okay. Well, I've noticed the discoloration. Like I had repaired the perforation using amalgam instead of using white MTA. And why I had that discoloration, even though I was using white MTA, because that white MTA used to contain bismuth, and bismuth is responsible of discoloration. The same company from Switzerland who produced the MAP system that I mentioned to you before, the microapical placement, they also make a different white MTA, which is called PD, Produit Dentaire White MTA, where they remove the bismuth. So this white MTA has several very nice characteristics. One, it doesn't cause any discoloration because it doesn't have bismuth inside. And second, the setting time, instead of being 3 or 4 hours like a ProRoot MTA, it sets in a 10-15 minutes, which is very useful, not only for surgery. Of course, I don't wait 10 or 15 minutes for the setting, but in restorative, for instance, in the case of direct pulp capping, you don't have to wait a couple of days for the setting. You can finish your patient in the same visit, because after 10-15 minutes already have the setting of MTA without any discoloration, because it doesn't contain bismuth.
Yes,
Okay.
thank you for explanation, doctor. We have the last question here. Mr. Limon asks, do you prefer using manual instrumentation or rotary file systems in combined canals? In other words, do you prefer one technique more than the other?
Very good question, and thank you. But let me tell you that today, and this is something I want to tell to the students, you, my dear students, you are very lucky, because today it becomes extremely easy to give a nice shape to the canal, because thank God the night-eye rotan instrument, they produce the shape for us. Years ago, only using hand stainless steel instrument was time consuming, was difficult, never predictable, easy to make ledges using number 10, 15, 20, and so on, K-file or Rimmer, was very, very difficult. Today, the only difficult part of Endo is the initial negotiation, where you use we have to use a hand stainless steel pre-curved file. This is the only time. Okay. Once you have negotiated the canal, today we have the night-eye rotary files with an O2 taper. They make the what is called the glide path. They make the preliminary enlargement. After you negotiate with the number 08 or 10, using, again, I don't have any economical interest on this instrument, but if you use, I don't know if you are familiar with the path files from Dentsply Sirona or Dentsply Mayfair years ago, okay? With these three instruments, or with the one instrument to replace the three of them, which is called ProGlider, you make the preliminary enlargement and you pre-enlarge for safety the foramen to a size where you can accommodate any other system you like in night eye. Remember that if you want to safely use any night eye rotary system, after negotiation, and I never use any rotary if I didn't negotiate the canal first. I want to know the anatomy. I want to know what kind of curvature obstacles I have inside there. So I negotiate and I go to the foramen to check the initial working length. Then to use safely any rotary system in night eye, you have to make room inside the canal to have the glide path, the smooth walls where the instrument can slip and slide and reach the working length. But at the same time, you have to enlarge, pre-enlarge especially the foramen to the same size of the rotary file that you will take there later if you want to avoid breakage. And then you can complete the finishing with the finishing files of the system. So I repeat, I only use the hand file for the initial negotiation, hand 08K file or 10, not more. After that, I use only rotary. The system that I use is ProGlider to pre-enlarge and prepare the glide path to the system that will make the shape. And then I use ProTaper next as a night eye system. In the system, I have the paper point to dry the canal and the gutta-percha point specifically designed for the shape prepared from the same rotary file. So again, today is extremely easy, much easier, no comparison to what I used to do after I came back from Boston University, only using hand stainless steel file. It was terrible. You are lucky today.
Thank you a lot,
Yes.
doctor.
And we have another question. Amir Hani asks, what is the diagnosis in case of delaceration, especially on mesial roots in mandibular and maxillary when wanting to do a root canal?
Now, what you mean exactly with delaceration? Delaceration means bifurcation of the canal at the apex.
I think yes, doctor.
Because as far as I know, delaceration means the canal it goes like this at the apex. Correct? Can you ask?
Yes, yes.
Yes, he said
Amir
yes.
said yes.
Yes, okay. Well, delaceration many times is something that you discover at the end. You don't know that you have such a bifurcation at the apex. So you prepare one foramen, one canal, and if you use vertical compaction of one gutta-percha, the other one will be obturated by itself. Okay? Sometimes, if the canal is elliptical and you have enough space to introduce one instrument here and one instrument there, and then two gutta-percha points, well, I have a case in one of my presentation. If I was in your country in front of you, I could take it and show it to you. It was a lower premolar with this delaceration, but was easy because the canal was elliptical. And through the microscope, I could see the one orifice and the other one. So I remember very well that I could introduce one gutta-percha point here, one gutta-percha point in the other one, do the compaction, and then in the final obturation, I have the main canal with the delaceration at the apex. Very, very nice. But that was because the canal was large enough to have a good view of everything. In many other cases, the delaceration is something nice that you see in your postoperative film, that you never found it. You never had this suspicion before. The beauty, I don't know if in your country is more popular, they call the lateral condensation of the vertical compaction of one gutta percha. But the beauty of the vertical compaction of one gutta percha, as another dentist said many years ago, the beauty of the warm vertical compaction is that at the end of your treatment from your postoperative film, you will know exactly the root canal anatomy that you will have prepared. If I don't have a copy here with me, but if I can go back for a second to my presentation. Okay. Do you see the cover of my textbook here? Let me start my presentation. This is the cover of my new textbook. And in the cover, I put together the my postoperative film, one here, one here, one here. And
Actually,
with the blue,
we still didn't see your screen, doctor.
you cannot see.
No.
Oh. What can I do? Share the screen. Let's see. Okay, no, it doesn't matter. However, if you will see the the cover of my textbook, are you familiar with the work made about 100 years ago by a Swiss man, Walter Hess? He introduced vulcanized rubber inside the root canal of maybe 2,000 extracted teeth to show the crazy and bizarre root canal anatomy. In front of this anatomy, many dentists became discouraged and they said, well, it will never possible to introduce instrument and obturating material inside that space, bifurcation, communication, lateral canal everywhere. In front of the same anatomy, Professor Schilder, my mentor, my teacher, came to this conclusion. Of course, with my instrument, I will enter in the negotiable canal and I will shape that canal. But with the irrigant, I will clean all the other bifurcation, communication, and lateral canal and so on, and I will digest all the organic material, bacteria, pulp tissue, and everything. Then, if I use some rubber, gutta percha point, soften that rubber, warm gutta percha, with the vertical compaction, not lateral, following a law of physics, the law of Pascal hydrodynamics, the softened material will enter in every empty space. And so I will fill the crazy anatomy wherever it is. And so in the cover of my textbook, I put together the work of Walter Hess with the crazy anatomy and the postoperative film of my cases, showing you that with the vertical compaction of one gutta percha, we can take care of any different kind of anatomy. Just follow the principle. So the anatomy of the work of Walter Hess is not the anatomy of 100 years ago. It's the anatomy of the patient who come every single day to our office. And if we don't see that anatomy in our postoperative film, we are missing something. Okay, so the delaceration is something that you discover in your postoperative film if you use vertical compaction. If you call lateral condensation, and also if you stay half a millimeter shorter, you will never see this bifurcation and this delaceration. That's for sure. Okay.
Yes, thanks for your
Thank you so
explanation,
much,
doctor.
Doctor.
I think these
Okay.
were our questions. Now, ladies and gentlemen, finally, we came to the end of part of our presentation. We would like to say thanks again to Dr. Arnaldo for the informative and interesting talk, and to our participants and audience. Saba?
Yes, I was moved tremendously, and I hope everyone used this lecture like I did because it was really useful. Thank you, Professor Castellucci and Dr. Abdul Jalil, for your amazing presence. May this phenomena continue stronger when held physically in North Cyprus instead of online. Now, I would like to invite Sarah to complete this speech.
Okay.
Etkinliğimize katıldığınız için teşekkür ederiz. Son olarak küçük bir hatırlatma yapmak istiyorum. Türkçe altyazılı haline sonrasında YouTube kanalımızdan ulaşabilirsiniz. Bir sonraki DENTALKS'ta görüşmek üzere. İyi hafta sonları diliyoruz hepinize.
Thank you for your
Okay.
attention. Goodbye.
Let me say one more time. Thank you
Yeah,
for
sure.
Professor Abdul Jalil. I don't know if I
Yes.
pronounced the name correctly.
Yes, right.
Thank you, Sarah, and thank you, Saba. I hope to meet you in person in the near future.
Of course, we are
Thank you very
interested
much.
waiting for you.
Yeah, thank you so much.
Bye bye.
Goodbye.
Saba.
Bye, Doctor. Bye.
I'm catching a bus. Never nothing when it's real, yeah.